And this time I'm going to take you through MIGS with a stent, and I have no financial interest. So, if you look at the ladder glaucoma therapy, current Indian approach, the gap you see out there after medications needs to be filled up with MIGS, minimally invasive glaucoma surgery. So, mild to moderate disease, we've heard a lot about this from Arvind, and Arvind has made my work simpler. So, it's basically to restore and maintain natural physiological outflow, safety profile compared to cataract surgery. It's almost same as cataract surgery alone, and maintaining the natural pathway can avoid atrophy of the Schlemm's canal. So, what capsular access is to phacoemulsification, direct gonioscopy is to minimally invasive glaucoma surgery. So, intraoperative gonioscopy is not just a simple task of docking a surgical gonio lens on the corneal surface. You have to identify the trabecular meshwork in the Schlemm's canal based surgeries. And the easiest way to do it is a provocative gonioscopy, where a forced reflux into the Schlemm's canal, which causes relative hypotony and blood reflux into the Schlemm's canal with IOP drop. And then you can again stain it with trypan blue, and that helps you to find the trabecular meshwork. So, what does en face really mean? When you're doing phacoemulsification, we do it coaxially. We look down and our hands are operating close to our body. But when you're doing a mix, that's where the actual catch lies for us and the cataract surgeons, is that you have to push back your chair and have an on fast view of the trabecular meshwork. Otherwise, this is how it's going to look if you have the coaxial views. So you can't do a mix in that case. So you have to bend the microscope towards you at 35 degrees and the patient's head about 20 to 25 degrees away from you. That's when you're going to get a on-fast view of the trabecular meshwork. So the mode of action of the various devices, I'll just limit myself to two of them since we just have two of them here at the moment in our country. That's the iStent Inject W and the Hydrus. So I wouldn't go through this. Arvind has already told you about how the Hydrus works. So I'll just show you a small video of the Hydrus in real time, and the animation, this is the Hydrus, very flexible, and it comes preloaded in an injector like this, which works both ways. The wheel, and you identify the trabecular meshwork and push it in, and that's how it goes into the Schlemm's canal. And you can also retract it. The wheel can be rotated anti-clockwise as well, where that shows the retraction process, and that's how you can retract it. So I'll just show you a real time of it. This is where you identify the trabecular meshwork, and you go into it and you push in the hydrus. You have to be very careful that you're into the Schlemm's canal, or else you could have uh, difficult job. There could be threading, there could be cheese wiring, and you might not get your desired results. But what is the catch thing here is that after you've implanted it, look very carefully. Almost 1,000 microns of it remains outside. This is where the entire thing, 1,000 remains outside and causes a concern for endothelial cell loss. Moving on to the iStent. The iStent is Inject W, as you know, is the smallest thing that we have in the medical world that is inserted into the body. And we use two of them in India at the moment now. It's a decade-long journey, started long back in 2012, and that's how the iStent is. I'll show you. These are the two stents which come in the injector. And the work of the eye stent is to basically make the flow through the natural pathway that we have through the trabecular meshwork. That is what an eye stent looks compared to a dollar. So you can imagine how small it is, and when it drops off, what a problem it is to pick it up, rethread it, and use it. So once you've placed both of them in that fashion, it reverses the flow, and that is how the flow takes place. So this is another video of that's a gonioscope eye prism from Glocos. Uh, Initially, I would advise you to use your Swan Jacobs, because the view is much better with glass, because this is acrylic and the view is not that good. But with practice, you can move on to this.
That's the injecting system of the iStent Inject W. The blue button is the sleeve retraction button, and the black one is the stent delivery button. To start the procedure, hold it in a pen holding manner, keeping your index finger free. Place your index finger on the blue button and enter the anterior chamber of the eye. Once you've crossed the iris margin, retract the sleeve to keep the plunger ready for insertion. Now place your index finger on the black button, target the trabecular meshwork, make a dimple, and release the stent with a single click. Do not remove the pressure from the black button until you have withdrawn. Remove your finger, close the stent once again, and move to the second side about 2 o'clock.
All right. So having seen that, have a look at this. This is one of those normal days when it looks eye stent is very easy to implant. And let me assure you, it is easy to implant, but you would have bad days as well. So this is where you make an incision like you do for your phaco, anterior corneal, and that's the eye stent. You identify the trabecular meshwork and you insert it as the previous video just said, 2 clock hours away from each other. Once you've implanted this stent, you move on to 2 clock hours away on the posterior trabecular meshwork and you insert the second eye stent. And that's really a sunny day. But have a look at this. This actually could also happen after that beautiful implant. So look at this. Everything goes right initially, everything is fine. But once the first eye stent is implanted, I realize that it's very, very bloody around there. I can't see anything. There's pressure on my gonioscope. You can see those corneal folds. I really can't see anything at all. So I decide to come out totally. You have to reverse the microscope, put the patient's head back, do your normal irrigation aspiration as you do following phacoemulsification. Then you'd again have to revert the microscope and go in again and implant it there and do a proper cleanup. This is the third one where look what
Yeah.
happens again. So I implanted that, and the moment I implanted it, I knew it's not implanted properly. And I thought, let me implant the second one, and then I'll come back and plug this one out and I'll rethread it. But by the time I implanted the second one, this had already fallen off. So I picked it up with a microrhexis forceps, and that's how you have to rethread it. The rethreading is quite a cat and mouse game, which you have to get used to and would happen once in a while. And then you have to go back again and you can rethread it. Just few seconds I'll take. That's the end of it. These are the post-operative pictures. This is our study accepted by the IGO on for publication, and that's from none other than Aiki Iqbal, the god of MIGS, where he compares head-on the integrity study where Hydrus with the eye stent, and he definitely claims that the eye stent is better than the Hydrus. So these are the pearls which Arvind has told you already. So thank you very much for your attention.
Yeah. Thanks, Dr. Chandrima. So before I give a concluding remark, Dr. Mathur, you want to have any comments about the whole session? Any suggestion? Any?
Yeah, thank you, Rajul. Like the glaucoma in its evolution, 1970s, it was a total revolution by the introduction of the beta blockers and then the advances in the medical management as it was highlighted during the session. Like the newer drugs pose different types of advantages as well as side effects. And all the drugs that were invented after timolol were compared to the efficacy of timolol. I'm as good as timolol. I'm better than timolol. I'm a less effective than timolol. What really changed the management of glaucoma is the introduction of fixed dose combination that really helped in the management of glaucoma. And now, during the current state, even the introduction of triple combination medication and now combination of PG analog with Rho kinase inhibitor netarsudil is also in the offing. And these offer multiple opens up a Pandora's box, and even 5 molecules of anti-glaucoma medication given in as low as 3 drops per day for the patient. So everything is not a mathematics model. Some drugs may work, some drugs may not work. The amount of complications, the side effects each drug provides, each case is a different scenario. And what is important in our scenario is the ocular surface side effects of anti-glaucoma medication in the long run. Probably the next way forward in medical management in glaucoma is for the companies is to think of introducing low-cost UNIM models so that uh, preservative-free anti-glaucoma medication may be the way to go forward.
Yeah. Thanks, Dr. Mathur. So, before I give my concluding remark, just one thing, Siddharth, when you said you don't follow the evidence only selectively, I would say I follow the evidence to the core. The only difference is that conclusion written in the article is not the evidence. The evidence is that you look the study design, results, and come to your own conclusion. That is the evidence for me. So I use all the literature to the core, but create the evidence what I want when I feel that scientifically making more sense to me, and that is how we have to go about it. So, because everybody is biased and everybody has their own thought of view, and they would try to push it to us. And it started way back. If you look the old study came with the conclusion that every ocular hypertension required treatment. We still don't treat all ocular hypertension. So we use and the data is there. It says very clearly you don't require. But it says that author wanted to push through the pharmaceutical company in USA, not in India. But that is how the evidence is diluted and modified. So we don't have to go into that part of the evidence. We have to create our own. Thank you. And thanks for listening to us for 2 hours. Thank you. And anyone has any questions, all the faculty is there outside. You can ask question because we are running late. Thank you.